Yeah, thank you. So I'm think one of the few pure nuclear medicine physicians in the room today, but I'm really proud to talk about the Symmetry because it is a really items of actuality. So how we won't define refractory, you read everywhere all the classes of, to define refractory thyroid cancer, but we'll try to show you if dosimetry can help us to identify patient with how can I go on with this? The green one? Okay, so these are my disclosures. So just to focus on which kind of population we are talking about metastatic thyroid patients that represent only a small part of the patient that we are able to cure, that we are used to manage, but it's a very heterogeneous population. So according to patient features, histology, tumor biology, and genomic profiles, and we are really heterogeneous prognosis. But we know that 2/3 of these patients become radioactive refractory during time. So the approach to this patient is like a circle. So we start from the patient characteristics at the beginning, so we have to know which kind of disease we want to treat or we are going to treat, and then according to the facilities, to the technical availability, the expertise of everyone center and radioprotection law, we decide which is the best radioactive iodine treatment for the patients. But we can have different modalities to perform this radioactive iodine. What we have to know if we can have a benefit for our patients, so to select if the patient can benefit from radioactive iodine, to distinguish from patients that become refractory. And these we can evaluate in, thanks to the evaluation of the response and the impact on outcome. So in the largest areas that are available, we know that, of course, if we want to use radioactive iodine, we need the radioactive iodine uptake. So we know that radioactive iodine uptake is present in 2/3 of the patients with distant metastases. In 1/3, there is no radioactive iodine uptake. So, but radioactive iodine uptake is not just an on-off phenomenon, so we have a really heterogeneous uptake, patient with really high avid metastasis, patient that are negative to radioactive iodine, and mild uptake. So refractory thyroid cancer still in between the mild and the absent uptake. So we start to identify which kind of patient that can be refractory, so patients that do not disclose radioactive iodine, and patients that lose the ability to concentrate radioactive iodine, according to also diagnostic or therapeutic whole body scans, and we know there are mostly poorly differentiated patients with FDG positive tumors. But then we have the tumor burden. We know that among the patients that present radioactive iodine, 1/3 go into remissions, and 1/3 has persistent disease and that are not cured by radioactive iodine. And the tumor burden is very important. These are the results of the empiric approach given 100 millicuries during time. And we know that young patients with really small metastases and negative morphological imaging, well-differentiated tumor can be cured by radioactive iodine. The problem are the patients that have uptake, the disclosed uptake of radioactive iodine, but are not cured. And are patients older with macromultinodular metastases and poorly differentiated tumors. So we have patients that goes well after several treatments of radioactive iodines. There are some patients that are not cured and they have still a persistent disease. And again, this is correlated frequently to really high tumor burden tumors. So there is a moment we have to think when we want to stop. And also the cutoff of the 600 millicurie has been proposed. This comes from the fact that in the empiric approach of radioactive iodine, we achieve normally response below this limit, and over this limit, we have a higher risk of long-term toxicity. The problem is, can we do better for the patient that disclose radioactive iodine but do not respond to treatment through the dosimetry. The dosimetry is very wide word. Dosimetry, we have the blood dosimetry that is based on the MTA evaluation, so the maximal tolerable activity, and so this way allow us to administer highest activity safely or to reduce the activity that we want to give to the patient, reducing toxicity, or we have lesion dosimetry. So we go to see which is the activity that can deliver the highest tumoricidal dose, based on the fact that there is a dose-response relationship. So dosimetry is time-consuming, but we can do now the technology that we have right now with the SPECT-CT or with the iodine 124 PET, and now there are several optimized protocols that are proposed both for SPECT and PET, and we performed MTA approach or lesional dosimetry with this technique. So what we know is the lesional dosimetry in particular says that independently for the activity that we give radioactive iodine, highest is the dose, highest is the response. And there is the 80 gray cutoff that has been proposed by Maxons, but now with PET we know that this cutoff cannot be cannot fit with all the lesions. We know, for example, that bone lesions have to achieve a really higher dose to respond to this treatment. And this is the information that lesional dosimetry can give us. And we know so that the absorbed dose and the response is in particular important for big lesion, while the small lesion we can achieve response also with smaller dose, with lower dose. And also the small volume lesion is the major limitation of lesional dosimetry because they are difficult to evaluate. This is one example of one of my patients which we performed dosimetry, and we can combine the approach. We can combine the MTA approach in the pre-therapeutic setting to understand which kind of activity we want to give to the patient respecting the bone marrow irradiation, and then once we decided the activity, we can go to evaluate the gray that are absorbed by the lesions. And we can also evaluate or predict these kinds of absorbed dose only also on the pre-therapeutic scan. What we know is, does the pre-therapeutic scan predict the dose that we can give during treatment? The first experience, there are few data about that, but it seems that the absorbed dose evaluated on pre-therapeutic scan can overestimated the real dose that the lesions received after the treatment. We don't know if really the thyroid staining that is the keys of these, if the really low iodine activity that we give to the patient does not allow really good quantifications. So the guidelines say that for metastatic thyroid cancer, we can choose the activity that we want to leave by an empiric or a dosimetric approach. So there is not superiority of one approach to another. And this is why in the literature we know that there is not a real evidence of the usefulness of dosimetry in terms of impact on outcome of the patient. So the studies that are available are low to moderate. There are really few studies that evaluate impact on overall survival, and the study available on dosimetry include a limited number of patients, and also dosimetry is assessed using different methods. So I reviewed all the papers that have been published on dosimetry during the last 10 years, and we can see effectively that in most studies we have low number of patients. We have only retrospective study on these, and the methodology to evaluate dosimetry can be very heterogeneous. And also the evaluation of impact in terms of tumor response can be very heterogeneous. The criteria that are used are based on RECIST criteria or thyroglobulin or or iodine scan, for example. So if you look, there are two studies that try to compare the two approach, empiric, so after the administration of fixed activity of radioactive iodine to MTA dosimetry base. One is from Washington, and the other one is a French-American study that we performed a few years ago, and we went to evaluate, to compare the outcome of patients treated with MTA-based dosimetry and Memorial Sloan Kettering and patients treated at Gustave Roussy with fixed activity of radioactive iodine. So both are retrospective studies. There are some differences, the population included in the studies. We included more than 300 patients. The other study includes a lower number of patients, include also local advanced disease. Our population was a little bit younger compared to the other studies and with higher tumor burden. So if we look to the activity that was administered in the empiric and dosimetry approach, we see that in the empiric group of our study received a median of 100 millicurie for each treatment, and was slightly lower compared to the activity administered in the empiric group of the other studies, while the dosimetry activity was quite similar. The preparations of dosimetry and treatment was quite heterogeneous, and the first study was some patients treated after thyroid hormone withdrawal or recombinant human TSH. In our study, the patients that were treated with empiric approach received radioactive iodine after thyroid hormone withdrawal, while patients treated at Memorial Sloan Kettering received in 80% of the patients treatment and dosimetry after recombinant human TSH. So which are the results of two studies? The first studies did not show any difference in the response among in the subgroup of patients with distant metastasis according to empirical and dosimetric approach, and no statistically different in progression-free survival. But what's interesting that in locally advanced disease, complete response was higher in patients treated by dosimetry approach, even if there was not a statistical significant differences in progression-free survival. There was a trend favoring the dosimetry group. In our study, at the first look, we can see that patients treated by dosimetry at Memorial had a worse prognosis compared to patients treated by empiric fixed activity at Gustave Roussy. But if you look at the characteristic of the patients, we see that Memorial patients were older with macronodular metastasis and with higher tumor burden compared to patients of Gustave Roussy. So that's why we decided to stratify the patient according to the age and according to the tumor burden. So if you look, you see that all the patients treated at Gustave Roussy received 100 millicurie for each treatment. Patients treated at Memorial received higher activity. We nuclear medicine prefer to talk and in gigabecquerel, but it's like 200, 250 millicuries. And again, we didn't find significant differences in overall survival in this patient in the through group stratified by age and tumor burden. So we give a higher activity based on the dosimetry approach, but we don't have a clear impact on overall survival, on patient outcome. So we confirmed that patients with higher tumor burden, older patients, are less likely to respond to radioactive iodine and to become refractory. But how we can explain these results? Both the studies didn't find significant differences. Lesional dosimetry maybe can give the response to the answer to this because we have seen that lesional dosimetry different lesions can receive really heterogeneous absorbed dose after treatment. This was one of the first studies published by Zgouros that showed that even the patients received a really high activity. Not all the lesions reached the absorbed dose sufficient to have a response. So even if we give higher activity, maybe not all the lesions receive the absorbed dose. That maybe is the key of the response of these lesions. And then we have the tumor heterogeneity. When we evaluate the distribution of the reactive in a lesion, we measure the mean absorbed dose. But we know that big volume lesions are really heterogeneous, so we can have some part of the lesions that disclose higher uptake and higher absorbed dose, and another part of the lesions that do not receive enough to respond. And particularly these heterogeneous lesions are the lesions that are most likely to be FDG positive. And then there is maybe the patient preparation. We'll talk about some preparation, thyroid hormone withdrawal, recombinant human TSH. There are some data that show that recombinant human TSH, the preparation with recombinant human TSH can deliver a lower radiation dose to the metastasis compared to thyroid hormone withdrawal. Even again, in the clinical study, we do not find memorial results, did not find differences in outcome in patients treated after thyroid hormone withdrawal or recombinant human TSH. So again, the lesional dosimetry maybe can explain that lesion that we are used now to be defined as refractory, so patient that disclose radioactive iodine uptake in some lesion but not in other. Maybe the fact that do not disclose a high radioactive iodine or not significant, it means they do not receive enough absorbed dose, so they do not respond, but can give pacemaker lesion and can be treated separately by the other lesion by, for example, local treatment. And then lesional dosimetry can explain as why some lesion, even in presence or radioactive iodine uptake, progresses during time. So to define dosimetry approach versus empiric approach, of course, the dosimetry is a real personalized approach, allowed to administer if we need higher activity safely, take into account patient toxicity on the MTA based, and take into account lesion biology through the lesion dosimetry, and show that there is a relationship between the dose that is given to the lesion and the response. Of course, it's a time-consuming approach. The best will be to have PET iodine 124 everywhere, but it's not available, unfortunately. But we can do this with SPECT, even if it's more time-consuming. It's not feasible in all lesions, so in small lesion, but maybe we are not interested because the small lesions are the lesions that respond better. And there is still heterogeneity in methodology to the different dosimetric approach, the pre-post MTA lesional dosimetry base, and of course we have heterogeneity of tumor biology, and these we cannot change. And then, based on the lesional dosimetry, we know that high activity do not release high absorbed dose in all the lesions. So there are some lesions that maybe can benefit or higher activity, and lesions that do not. So there are not clear clinical data on the superiority of the dosimetry approach compared to empiric approach in terms of outcomes, but I think that in the future, lesional dosimetry will become a very important element to be introduced in the definition of refractory thyroid cancers that is continuously updated, and together with imaging technique, imaging quantifications, and the better knowledge of a tumor biology, together with molecular testing, we will be able to define more precisely the patient that do not benefit of radioactive iodine. Thank you for your attention.